Hello, dear friends. Greetings for the day. At the outset, I'd like to thank AORA India for giving me this opportunity to be presenting a webinar on airway ultrasound. I bring greetings from Asian Institute of Medical Sciences, a multi-specialty hospital situated in Faridabad in the heart of Delhi NCR. These are my set of disclosures. I do not have any conflict of interest. It's just that I am a great regional anesthetist as well as POCUS enthusiast. You will find a couple of QR codes. If you scan them, they will directly take you to the landmark articles. My references are from PubMed, and there are a couple of images which are from Google. So, my dear friends, what are the learning objectives for airway ultrasound? First, we'll try to understand the I-AIM framework of POCUS, the sonoanatomy of the airway. We'll try to understand the curriculum which is available to us for airway POCUS and the various perioperative uses of airway ultrasound. So as early as 2012, David Banner and colleagues gave the I-AIM framework, which has to be followed for any modality of POCUS which we are doing. I-AIM is an acronym which stands for I stands for indication for which POCUS is being performed. A stands for acquisition of image for that modality and optimization further. Another I stands for interpretation of that image. And finally, we land up at a stage of medical decision making. So, in order to perform airway ultrasound, ergonomics has to be followed. So, majority of the POCUS modalities, if you look at the individual, that is the operator or the anesthesiologist, stands on the right side of the patient, and the machine is always on the same side, so that with the other hand, one can save the images and annotate them if needed. So this is one of the ergonomics where as you can see, the patient position is sniffing as you would do for an intubation. I'm standing on the right side. Ultrasound machine is on the same side so that I can manipulate the knobs. And the aspect marker depends on how are we scanning. For example, if you are scanning in the transverse axis, then it will point towards the patient's right side. And if we are scanning the airway in the longitudinal axis, the aspect marker would be pointing towards the head end. Alternatively, if you do not have enough space to stand on the right side of the volunteer or the patient, another alternative ergonomics is that you can stand on the head side as you can see in this figure. So again, the patient's position would be sniffing. And as you can see, the operator is standing on the head side. Now the USD machine has to be at the left side at the same arm level. Aspect marker now for transverse scanning would be on the left side, whereas for the longitudinal scanning, it would be still remain on the head end side. The reason for this is to maintain a synchronization between the side which we are visualizing and the same it appears on the ultrasound screen. So up till now we have studied the ergonomics. Let's now delve into which probe should we be using for performing the airway ultrasound focus. So airway ultrasound for suprahead evaluation, since these are deeper structures, we are trying to visualize the floor of the mouth, tongue, and the palate. We use the curvilinear probe. And for intrahead evaluation, these structures are generally superficial. So a linear probe does the trick. And what about the preset? Every ultrasound machine will give you a certain preset, and the best preset will vary between the musculoskeletal or the lung or at times nerve. Depending on the machine you have, at times you may not have the lung modality, then you can choose either between the MSK or the nerve. If lung is available, prefer that over the other two. So what are we supposed to evaluate in airway ultrasound? What structures we are supposed to see? This is one of my favorite actors, Anil Kapoor. If you recollect, in early 1980s, there was a famous movie in which he sang a song, One, Two, Ka, Four. So easy mnemonic for remembering what all structures we are supposed to visualize in airway ultrasound. It's 1, 2, 2, ka, 4. So 1 stands for hyoid bone. Another 2 means soft tissue structures, tongue and esophagus. 2 membranes, the thyroid membrane and the cricothyroid membrane, and the four important cartilages of the upper airway, starting from the above, that is the epiglottis, then the thyroid cartilage, then cricoid cartilage, and subsequently the tracheal rings. So, in order to visualize these nine structures, we have five important views. As we had discussed while while choosing the appropriate probe, we had discussed that for supraheight evaluation, since it's a deeper structures are to be visualized, we use a curvilinear probe, and for rest structures, we'll be using a linear probe. So, first view is the supraheight view. Then we can descend downwards and visualize the thyroid membrane and the various structures, then through the thyroid cartilage, then through the cricothyroid membrane, and subsequently suprasternal view. The sequence of scanning from cranial caudal or caudal cranial will depend on the preference of the anesthesiologist. So let's come on to each view. For each view, my dear friends, we need to answer three pertinent questions. Number one, how to obtain that view? What all structures need to be identified in a particular view? And what are the uses of that view? So let's understand the appearance of the various structures, which I had told you 1, 2, 2, 4, 9 structures. How do they actually appear on ultrasound? Cartilages, which are 4 in number, would appear hypoechoic, my dear friends. That is little black. Membranes would appear hyperechoic, that means more white. And the bone is characteristically seen as a hyperechoic shadow with an acoustic dropout. So let's understand the interaction of the ultrasound wave with the air which is present in the upper air. Because of the difference in the acoustic impedance of the skin, subcutaneous tissue, and the various soft tissues, the ultrasound waves are strongly reflected back, thereby resulting in a reverberation artifact, which appears a series of parallel hyperechoic lines, and it is seen as a wide hyperechoic line which is known as air mucosal interface. This is almost similar to the A lines which we see in the lung ultrasound, thereby meaning the structure underneath cannot be visualized with certainty. So our aim is to identify air mucosal interface in the ultrasound for airway scanning, particularly in the longitudinal axis as well as in the transverse axis. Now, one by one, we'll try to study various views, what are the structures to be visualized, as well as what are the perioperative uses for that particular view for the anesthesiologist. So, my dear friends, supraheight view is classically used to visualize the tongue, and generally it is done in longitudinal axis, and it can be done also in transverse axis also. This view is particularly useful for calculating some of the distances, which can help us in predicting difficult airway, which we'll study in subsequent slides. So once we place the probe in longitudinal orientation with the aspect marker pointing cranially, as seen in this figure, the patient in the sniffing position, we can clearly visualize two bony structures, one the mentum, another one the hyoid. And we can calculate the distances, the hyomental distance in neutral position, in extended position, and the ratio, extended by neutral and ramped by neutral. And we can also estimate the tongue thickness. So as you can see for yourself, the bulk of the tongue is found by the genioglottis muscle, which is clearly visible. Then two white hyperechoic shadows are visible. One is the tongue surface and another one is the palate. Please try to understand that is a flipped image. We are trying to visualize the floor of the mouth from the underneath structure, not from above. So in the far field, we'll be able to visualize the hard palate as white hyperechoic structure. So what are the distances which have been found out in various RCTs as well as systematic reviews, which can pinpoint towards difficult airway in this view? Is the hyomental distance in neutral position. If it's less than 5.29 centimeters, it can indicate a difficult airway. If the ratio between the extended position and neutral is less than 1.08, or the ratio between the ramped and the neutral is less than 1.12, and the tongue thickness is greater than 6.1 centimeters, these are indicators of difficult airway. Now coming on to the next important view, that is the thyrohyoid view. In thyrohyoid view, we are trying to visualize the thyrohyoid membrane, the epiglottis, and this view can be useful in performing the airway blocks, particularly the superior laryngeal block. So, as we had studied, any bony structure would appear hyperechoic with the acoustic dropout. So, hyoid bone appears like any other bone in the body, and you can visualize it in transverse or longitudinal orientation. This view is about transverse orientation. It appears as an inverted U with an acoustic dropout, and the distance from skin to hyoid bone. If it's more than 1.4, it's an indicator of difficult airway. Now, coming on to another important structure which is visualized in this view is the thyrohyoid membrane, which is a white hyperechoic line, as you can see for yourself, connecting the hyoid bone, which appears as a white hyperechoic line with a acoustic dropout, and the thyroid cartilage. Cartilages are hypoechoic. Underneath, as I told you, because of the difference in acoustic impedances, we get a air mucosal interface. Please have a close look at this figure. If we have to give a SLN block, we are not in the strict midline sagittal view. We are paramedian parasagittal, and my needle can come in out of plane and deposit 1 to 2 ml of the local anesthetic after piercing this membrane, and this membrane would result, this technique would result in a SLN block. Now, coming on to another important structure which is identified in this view is the epiglottis. As anesthesiologists, we know the importance of epiglottis. So, in the transverse view, epiglottis appears as a hypoechoic structure. And if you have a close look, strap muscle as well as the pre-epiglottic space and the epiglottis resemble a neonatal face sign, or some anesthesiologists term it as small face sign, wherein the strap muscles represent the eyes, the pre-epiglottic space, which is hyperechoic, represents the nose, and the epiglottis itself represents the lip. This is a very characteristic appearance, and no one can miss it if you move slowly, either caudal cranial or cranial caudal. A very important distance which has been used to identify difficult airway is the distance from skin to epiglottis. If it's more than 2.5 centimeters, it is an indicator of difficult airway. Now coming on to another view, that is the thyroid view through the thyroid cartilage. And thyroid cartilage serves as a window to identify the vocal cords. So as we know that vocal cords are visualized through the thyroid cartilage, and they are seen as hypoechoic structures lined by a white hyperechoic membrane. So in general, their appearance would be hypoechoic of the true vocal cords, whereas false vocal cords, which are situated a little superior as well as little lateral, they would appear as bushy structures and as white hyperechoic structure. So, and for anesthesiologists, it's very important to evaluate vocal cords, particularly after thyroid surgery and parathyroid surgery. There are various maneuvers suggested, various techniques suggested, such as doing a direct laryngoscopy, video laryngoscopy, inserting a supraglottic airway device, or direct examination with the help of fiber optic scope. So these are the various maneuvers. But whosoever has done a thyroid surgery would realize that these maneuvers at times are quite distressful for the anesthetist as well as for the patient. So, evaluation of the vocal cords with the help of the ultrasound is very easy. Once the spontaneous efforts start, the dressing has been done, the probe can be placed above the dressing with a slight caudal tilt so that you can visualize the vocal cords through the thyroid cartilage and observe the movements. There would be classical movements in case if there is some paralysis or paresis, the movements would be sluggish, which can be easily identified on airway ultrasound. And this has progressed to the stage of systematic reviews and meta-analysis, thereby confirming that this technique holds good validation for identification of vocal cords. Now coming on to the cricothyroid view, which is very important for an anesthetist to identify cricoid cartilage. to identify the cricothyroid membrane. And in pediatric patients, because it happens to be quite narrow portion, we can estimate correctly the endotracheal size which the pediatric patient is going to take. So, my dear friends, how does cricoid appear? Cricoid cartilage, as other cartilages, is hypoechoic. It's an inverted C shape, as some of the anesthetists called it, or a signet ring, or it has got a horseshoe shaped appearance, which can be easily identified in. So there are various ways to identify. One of them is palpatory method, but the easiest one, if you start using ultrasound, this is the easiest method to identify correctly the cricoid cartilage. So as I was saying, there were various methods to identify. One of them is palpation method, four-finger method, and neck creases. All these techniques have been compared in this article, and none of them is absolutely foolproof that you can identify the required cartilage in 100% of the cases. Some is 62%, and that too, it takes a lot of time. So, in order to identify, we have two ways to do it. One in transverse orientation, which is known as a TACA technique, which I'll be discussing in subsequent slides. And another is in the longitudinal orientation, which is known as string of pearl appearance. So it has been observed in various studies that ultrasound increases the probability by almost 5 times more for the correct identification of required cartilage in difficult airway scenarios. So let's understand the TACA method to identify this membrane. So TACA method was advocated and published in British Journal of Anesthesia in 2016 by Christensen and colleagues. It's an acronym. T stands for first you identify the thyroid cartilage. Once done, you move your probe a little caudal, identify the cricothyroid membrane, which would be represented by a air mucosal interface. Then move a little further down, you would be able to identify the cricoid cartilage, which is the inverted signet ring or the C shape. And now further, once you have identified the cricoid cartilage, the next step is to move back cranially upwards so as to again come on the airline that would reflect the cricothyroid. This is the sono anatomy video. Let me play it for you. Okay. So the first step is to identify the thyroid cartilage, which is appearing as a hypoechoic inverted V. Air mucosal interface is seen. As I keep moving down till the time I am able to identify the inverted T-shaped hypoechoic cricoid cartilage. Now I have reached this place. The next step is to go back above, that is, go back again cranially to again identify the air mucosal interface. We have almost reached there. So we can mark it with the help of a needle or with the help of a skin marker. Now coming on to how do we identify this membrane in longitudinal axis? This is known as string of pearl appearance. So let me play a small video so that we can understand how do we identify in longitudinal axis. As you can see for yourself, the tracheal cartilages are visible. And once you reach the cricoid cartilage, there is a step up appearance, which is clearly visualized. Underneath is the air mucosal interface. The cricoid cartilage appears as a bean shape. The underneath is an artifact. The thyroid cartilage, which is situated cranially, would also appear hypoechoic. The white line, as you can see for yourself, which connects these two cartilages, represents the cricothyroid. Once centered, we can have our needle slide underneath and do a marking with the help of a skin marker. Please remember that this marking has to be done in a sniffing position, because if you land up in a cannot intubate, cannot oxygenate scenario and you wish to perform cricothyroidotomy, it would be always done in extended position, that is sniffing position. If you do a marking in a neutral position, then it will defeat the purpose. So some of the anesthesiologists use an analogy that for a low ejection fraction patient, for example, 20-25%, you secure the radial artery prophylactically. So why not, if you're dealing with a difficult airway, even if you have the best of gadgets in the form of video laryngoscope, fiber optic scope, why not mark it? And if you are able to secure your tube with the help of a fiber optic scope, it's well and good. God forbid if you need then the marking is there and it will help you in doing the cricothyroidotomy very quickly. So now coming on to pediatric patient, we can estimate the inner diameter of at the level of cricoid cartilage, which would reflect the outer diameter of the endotracheal tube. And for pediatrics, we know this is almost the narrowest portion, and thereby we can identify the correct size tube which the individual kid is going to take in. There are formulas definitely, but at times formulas may not be appearing that correct. This is the big advantage of ultrasound. Now coming on to a very important view, that is a suprasternal view, where we actually identify the trachea, esophagus, and we use this view for distinguishing whether the tube is in trachea, esophagus, or it has gone into one of the one of the mainstem bronchus. This view can also be used for performing percutaneous dilatation tracheostomy, and as well as correctly predicting the size of the double lumen tube which we require for performing thoracic anesthesia. And this we can also help whether the Rayleigh tube is passing through the esophagus or not. So, my dear friends, how does trachea appear on ultrasound in transverse axis and longitudinal axis? Trachea is another cartilage, so it would appear hypoechoic with the air mucosal interface underneath and reverberation artifact. In the longitudinal axis, it would certainly appear as string of pearl appearance. So as I said in that video, tracheal rings can be identified individually. You can count them. And once you reach the cricoid cartilage from caudal to cranial, you will identify a step-up appearance. If you are scanning in the reverse direction, it would be step-down appearance. And you can identify white hyperechoic membrane, that is the cricothyroid membrane between the thyroid cartilage and the cricoid cartilage. So how do we identify esophagus? For identification of esophagus, we slide the probe little towards the left side. And in the suprasternal view, the esophagus would be visible as a soft collapsible tube. For example, in this video, as I'm pointing out, you can see it is appearing as a soft collapsible tube. If accidentally I insert my tube into the esophagus, you can see for yourself, there would be expansion of the esophagus, and this would lead to a presence of another air mucosal interface in the esophagus where it is not normally present, and this is known as double track sign. Again, watch for itself, the esophagus will expand with the tube in real time, and you can see two air mucosal interfaces. This is known as a double track sign. Plus, in case you are inserting the Rayleigh tube and placing the probe on the left side of the suprasternal notch, you would realize for yourself that in real time you can visualize the Rayleigh tube being passed through esophagus. So, next important thing is which comes for anesthetist, critical care physician, as well as ED physician, is my tube correctly placed? Has it not gone into the esophagus or the main stem bronchus? So, in order to correctly identify whether my tube is inside the trachea, first and foremost is you can place the probe in the suprasternal notch and observe the passage of the tube in the trachea in real time. Once it does that, as you can see for in this video, there would be an expansion of the trachea. This is known as the snowstorm sign. Another important thing would be that it gets changes in shape. The moment tube is inside, it will get it will look like a bullet. So this has been termed in literature as bullet sign. Ultrasound is all about recognition of patterns. For example, we do a supraclavicular brachial plexus block recognition of bunch of breaks. So in order to confirm my tube is inside the trachea, there are three important things. Number one, positive bullet sign. That means the contour, the shape of the trachea would change. The positive snowstorm sign in real time visualization. That means you are keeping the probe on the suprasternal notch, and whosoever is doing the intervention is performing the ET2 penetration. And a negative double track sign. Double track sign, please recollect, as I said, it would be visible once the tube is inside the esophagus. So, a positive bullet sign, a positive snowstorm sign, and a negative double track sign gives me assurance that my tube is inside the trachea. So how do I distinguish whether it has not gone inside the main stem bronchus? If my tube is in the trachea, then lung sliding, which we see for lung ultrasound, would be present on both sides, that is right and left. If my tube has gone onto the right mainstem bronchus, then the lung sliding sign, my dear friends, would only be visible on the right side, whereas left side it would be absent. If it's gone on the left side, then the lung sliding sign on the left side would be present and right it would be absent. This is how, by using these two maneuvers, which I've told you, you can identify whether your tube is in the trachea, esophagus, or mainstem bronchus. What about double lumen tube size? So traditionally, we have been using formulas or various methods to identify the DLT size. As early as 2008, article was published and which showed that if you measure the tracheal diameter at the level of sternoclavicular joint, it gives a good guidance as regards to size. For example, if the tracheal diameter is around 15.9 millimeters, the individual is going to take 32 French. If it's around 21.2 millimeters, it would be around 41 French. So this is a quite easy uh, intervention which you can perform. You can have the patient on your table, OT table, measure the diameters, and then correlate, have a chart with you, and do a good correlation. As anesthesiologists, as intensivists, we sometimes have to do percutaneous dilatational tracheostomy. There are n number of randomized control trials as well as meta-analysis which prove the utility of airway ultrasound for PDT, particularly in obese patients who are having short, thick necks. If there is a previous neck surgery, radiation has been received, or there is a neck march or tracheal deviation. First and foremost, the airway ultrasound helps in identification of the trachea. That's what I've already shown you. You can count the number of rings and you can choose the appropriate space for performing PDT. You can choose the tube size also. Identify the vessels if they are in your plane. And in case you feel there are so many vessels, it's better to go for a surgical tracheostomy rather than a dilatation tracheostomy. As anesthesiologists, we are always bothered about airway. So can ultrasound help us in predicting the difficult airway? The answer is big yes. Almost 40 plus parameters have been studied in various studies. But out of these parameters, out of these 40 parameters, we would realize that distance from skin to epiglottis is the most utilized. Then other parameters are also utilized in the form of distance from skin to hyoid bone, distance from skin to vocal cords, tongue thickness, hyomental distance, as I told you, to measure in neutral, extended, and ramped, and thereby calculate their ratio. So we are living in the era of evidence-based medicine. You will question me. You say these parameters are preferred over the rest of the parameters. Do you have any evidence? I am quoting almost four systematic reviews and meta-analysis, very recently published. They have clearly stated that out of more than 40 plus parameters, these 5 to 6 parameters hold good value. Very recently, in 2023, we had a protocol published, which is known as the DARES protocol, which stands for Difficult Airway Evaluation Using Sonography Protocol. The first and the foremost view is, first and the foremost part of this protocol is through the thyroid view, measure the distance from skin to epiglottis. If it's more than 2.54 centimeters, it would indicate difficult laryngoscopy and the difficult airway. Then look at suprahyoid view and measure the high mental distance in neutral position and the tongue thickness. If the higher mental distance is less than 5.29, it indicates difficult laryngoscopy and intubation. If the tongue thickness is more than 6.1, you have all the three parameters which will land up into difficulty, be it laryngoscopy, mask ventilation, and intubation. Next, calculate the ratios from in neutral, extended, and the subsequent ratios. If it's less than 1.08, then it indicates difficult laryngoscopy. If it's less than 1.12, particularly in the ramp position, then it indicates under difficult laryngoscopy. So everything is normal, then it becomes a normal airway predictor. So one can essentially take up a thesis or a study to validate this protocol against the standard measure. So we have studied various views, what are the structures to be identified, and what are the uses for an anesthesiologist in the perioperative. The next question comes to mind is, Is there any defined curriculum? Answer is big yes. The American Society of Regional Anesthesia has published a beautiful article in 2021, and you can scan this QR code where they have actually given why do you need to perform airway ultrasound, what are the structures to be identified, how do you interpret the image, and how do you take decision. So this is what I have covered up till now. This is what is stated by them. What is the minimum number of airway ultrasound scans which are required for gaining competence? So again, ASRA colleagues have published that in two categories. One is level one studies, where you are actually performing and interpreting under guidance. Level two studies are that these are interpreted by you, but they may not be personally performed by you. So for airway ultrasound, it's 30 for plus 20, so it's around 50 studies. For majority of the focus modalities, it's 50. But if you look at FATE or focused cardiac ultrasounds, it's 50 plus 100. That means you need 150 cases. So that is the most difficult part. Rest with 50 scans, you achieve reasonable degree of competence. So whatever I've said, the online resources are from POCUS 101 as well as ASRA, American Society of Regional Anesthesia Pain Medicine. You can visit and you can scan this code where they have actually written articles on almost each and every POCUS modality. Some of the figures which you had seen are actually from these sites. So my dear friends, this brings me to the tail end of this video recorded presentation. So always take baby steps. Learn to identify bones, cartilages, and membranes. First and the foremost structure which we need to identify is the cricothyroid membrane, and it has to be essentially step bladder approach. Thank you very much for patient listening.